So let's turn our attention to kind of the side effects, because many of the side effects that we've grown up with around these targeted agents have been built on the back of very rigorous schedules and very rigorous dosing from pivotal trials. And what I'm hearing from all of you are that you really practice clinical oncology, which is you tailor the approach to the individual in the setting that they're in. But Brian, what are still some of the recurring side effects that make you pause and think about changes in either dose, schedule, or agent?
So, I mean, when I'm counseling patients before I start them on, say, sunitinib, I usually say there are 5 side effects. High blood pressure, which I think is easily manageable. I've never changed a dose or stopped a drug for high blood pressure outside of maybe a patient who had RPLS or something, very dramatic. Fatigue, probably the most common and probably the most troubling to patients, and certainly, at least on sunitinib, builds up over 4 weeks, and then obviously gets better during the break. Hand-foot syndrome, also really similar to fatigue, I don't think quite as troubling for most patients. Diarrhea, which tends to be certainly the side effect that patients deal with more chronically, especially with axitinib, and then I usually say like mucositis, soreness of the mouth, which also doesn't tend to be as dose limiting. Those are the kind of ones that tend to be most common and drive my decision making. I would say in terms of schedule and dose alteration, probably fatigue if I had to pick one. That's the number one that makes me change behavior.
Jen?
I just would like to make a comment with an anecdote. 2 things. First of all, with oral therapy, you never really know what your patients are doing because they will tell you what they're doing, but they may not be. But early on, I had a patient on sorafenib, which was a twice-daily drug, and he was a golfer, and he loved to golf, and he said he could not live without golfing, and he had terrible diarrhea. So he got to a point where he would stop the night dose, hold the morning dose, go out and golf 9 holes, and come back in and resume his medication, and it did not alter his response to the drug, but it kept him psychologically in a much better place.
Yeah, I actually think, and I totally agree with that. I mean, I've certainly seen some patients that start to modulate how they receive their drug, despite our writing on the prescription, take 2 pills twice a day, because they're trying to manage that in the context of their life. And I think that's totally appropriate. But Jan, there's some black box warnings that we have to be aware of. And also for agents like the mTOR inhibitors, there's hyperglycemia and hyperlipidemias. How do they fit into your paradigm?
Okay, so the black box warnings are with pazopanib and sunitinib, and they're related to hepatotoxicity, which can be very extreme and require you to stop the drug. You monitor the liver function tests on a monthly basis, stop the drug if it's anywhere above grade 3 or higher, and wait for it to resume or decide not to resume the drug. Similarly, the RPLS, which can be a manifestation of hypertension out of control, but it does occur with all of the anti-VEGF TKIs, and that's an absolute requirement for stopping the drug. In terms of the mTORs, hyperglycemia and hyperlipidemias are real, and they need to be managed, and it makes it very difficult to treat some of our renal patients who come in with their metabolic syndrome and diabetes. So then, we do treat the diabetes and we monitor it. And I treat the lipids as well, because if they're going to be on the drug for an extended period of time, they need to be managed, and it has to be monitored.
Yeah, and Chuck, I know that we've talked about this extensively in the past. Doctors are important, but probably the team that supports the doctors is more important than the physician in managing the side effects on a regular basis, whether it's by call or in person. So in your community, what's the role of your nurse practitioner and your physician extender in taking care of these problems?
They play an essential role. They handle the initial phone call. They become fairly expert at side effect management in terms of instructing dose withholds or dose reductions. The physicians themselves have become more expert in managing hypertension and skin reactions than I'd like to be. The diabetes I tend to turn over to endocrinologists, but the physician extenders, the nurse practitioners, play a valuable role in handling the many phone calls that come in with complaints of side effects.